So I know that a big conversation you and I have had over the years is the medical system and why they push surgery and who runs the system. But if there's so much data that active surveillance is safe, it works, it can delay, invasive and side effects, all these issues, why do you think the medical community hasn't adapted to it, considering the science is so strong?
It might be the power of the word cancer. The word cancer gets used a lot because it's a common problem, but it doesn't lessen the ugliness and the scariness of that word, because most cancers are deadly. And if we can ever get around to changing the name of Gleason 6 to something besides the word cancer, maybe the doctors and patients would be more comfortable with treating it realistically rather than emotionally.
What do you do if a man chooses active surveillance, but his entire family, because they've heard the word cancer, is just terrified? Do you have any tips on how we can kind of discuss those topics with them and give them some sense of security?
Sure. I mean, have them come in and talk to the doctor. It's very hard for patients to explain. Another piece of advice I give is, since the grade 6 type of prostate cancer honestly isn't really a cancer, it doesn't metastasize, doesn't behave like a cancer, limit the circle of people that you start talking about. If you want to go out and tell everybody you have cancer, they're going to get confused. And they're going to wonder why you're not treating it. Are you in denial? Do you have a crazy doctor? Or it doesn't make sense. It takes a lot of skill to explain how something that is called cancer actually doesn't need treatment.
So if a patient has confirmed it's Gleason 3 + 3 = 6, they've decided to go with active surveillance, maybe they've done their own research, what would you suggest if they have a doctor who is not in agreement?
Well, this is the beauty of our, we're not, at least many of us have the discretion with our insurance to go to a different doctor. It certainly gets more difficult if you're in an HMO and you're locked into a certain doctor, though oftentimes they'll let you see a different doctor within the system. The doctors taking care of prostate cancer are usually surgeons or urologists, and it would be very reasonable to request a second opinion from a medical oncologist within that same system. And sometimes you just have to dig your heels in. The first book I wrote, Invasion of the Prostate Snatchers, Ralph Blum was advised to have surgery half a dozen times over a 15-year period, and he just dug his heels in and passed away at age 84 of nothing related to prostate cancer.
So, we've discussed 3 + 3 = 6 when it comes to Gleason and that being safe when it comes to active surveillance. But what do you do? I know we talk about it in the staging guide for PCRI. When you have 3 + 4, do you treat the system of active surveillance any differently since it's in the teal category? What is the differences between the two mainly?
So the thinking on what kind of prostate cancer can be safely watched has evolved since probably 2008, when active surveillance first came as an accepted methodology. And the doctors have realized that they can expand the category of men that can be safely watched even into some individuals that have favorable types of grade 3 + 4. That would be a Gleason grade 7 or a Epstein score of 2 rather than 1. And that's a selective process. The amount of grade 4 in the biopsy is sort of the driving factor. But it certainly is a more sophisticated question. But I think the bottom line is patients should be aware that some forms of 3 + 4 can also be monitored. Historically, it's only been the 3 + 3s. But there are some 3 + 4s now that experts agree can be safely monitored.
Thanks for watching. For more information about active surveillance, you can visit our website, PCRI.org, and please subscribe to our YouTube channel. We come out with new prostate cancer videos every week.